This is Matt Abrams with Medical Device Matt. Super excited for today's guest, Dr. Roy. He's just finishing up Interventional Cardiology Structural Heart Fellowship at Johns Hopkins, a very prestigious academic institution. Really excited to dive into his story. I want to pass it to Dr. Roy to talk about his story today, and then we're going to get into why he chose first cardiology, then interventional cardiology with a specialization in structural heart.
Thanks, Matt. Thanks for having me on. I'm very excited to do this interview. Thanks for the opportunity. And yeah, my name's Sumon Roy, and I'm originally from the Boston area. I did my college and grad school, med school, all of that up in Boston. And then I went on to Rochester for internal medicine residency, by which point I knew I definitely wanted to go into cardiology. My journey took me to Richmond, Virginia after that, where I did my cardiology fellowship. And now, yes, like you said, I'm here at Johns Hopkins now in Baltimore. I did interventional cardiology last year, and I'm currently a structural cardiology fellow. It's been a bit of a journey, and I'm very excited to be approaching the end.
Congratulations. Before we talk more about your story in medicine, I knew you played basketball, but I didn't know you grew up in Boston. So are you pretty happy this week with the Celtics getting the championship?
Yes, yeah. So I've definitely been very spoiled in my adult life with the number of overall championships the Boston area has generated for me. It hasn't generated a lot of friends for me outside of New England, but within New England, yes, it's been great.
That's funny because I think the longest drought for all your sports is like 4 or 5 years, which isn't long at all. And this podcast, I'm coming live from Los Angeles, growing up a Lakers and UCLA fan, so there's a rich history.
Yes,
So interventional cardiology and then structural heart is probably one of the longest trainings in the MD field, right?
Yeah, it's definitely up there. You need usually 8 years to go from the end of med school to the end of structural.
And then looking at your time in your internal residency, what was the experience that solidified cardiology for you?
I think I had the interest coming in, honestly. I think when I was in med school, I had a lot of interest in even going back to anatomy, when we actually did the dissections and working with the cadavers. And starting back then, I knew I was drawn to the heart. I had other interests as well. I spent some time thinking I might do, ortho or ophtho, other types of things. But it always came back to cardiology. And then when I went into residency, just being on those rotations, sometimes you're on a rotation where you're just not as drawn to the underlying pathology and material. But with cardiology, that was never an issue. Interventional always appealed to me, even before, because I always found that the privilege of being kind of at that threshold of something being very, very acute in a patient's life and having the opportunity to intervene upon that was appealing, intimidating, but it was definitely appealing more than too intimidating, which ultimately brought me to this point.
Awesome. So you did well in cardiology, and then eventually you chose interventional cardiology. At that time, it sounded like you were thinking about it, you were open to it, and you did decide to pursue interventional cardiology. Was structural heart ever a thought?
Yes, it was. So I think when I was finishing residency, I knew I wanted to do cardiology and then interventional. Interestingly enough, I probably spent most of my first year of cardiology fellowship kind of being brainwashed about electrophysiology as a subspecialty, and so I thought about that for probably the entire first year. But ultimately, I did come back, and so sometime early in cardiology fellowship, as I kind of cemented my thoughts on going into interventional, I realized that structural is very appealing. It was a later interest of mine. I just didn't have as much exposure to it, and of course, TAVR has been around for theoretically about 20 years now, but it became more common only in the last few years. And so I think that's when I also kind of became more aware of the opportunities we have from a percutaneous standpoint to intervene upon cardiac valvular issues as well. So I was like, wow, if I could do interventional, and then to me, it seemed like structural would be holding the future in terms of valvular heart intervention. And so that's what kind of got me into that.
What's crazy, 20 years sounds like a long time, but there's a lot of innovative therapies, first in man, that you are participating in, right? We talked about TAVR, but what's funny is when you talk to your attendings, or I talked to an attending out in Los Angeles and said, oh, this is so cool that you're the forefront of structural heart and TAVR. And he looked at me and was like, Matt, PCI was just starting when I was an attending. And PCI or, standing coronaries was one of the biggest changes in healthcare and medicine, right? And he's like, Matt, since the beginning, I've been at the innovative forefront of cardiology treatment. So looking at what you're doing, you do TAVR, but you're also treating all the different valves. And for people that don't know what a structural heart interventional is, can you briefly describe what you're doing?
Absolutely. So interventional and structural cardiology are certainly intertwined, but they are for all intents and purposes, two distinct fields. Interventional cardiology is generally going to be the practice of intervening upon coronary artery disease. And so the coronary arteries are the vessels that supply blood to your heart, which may sound a little strange, but the heart supplies blood to the entire body. But the heart itself needs a blood supply to beat properly. And that blood is provided by what's called the coronary arteries. These coronary arteries develop atherosclerotic plaque over years in many people. And if it reaches a critical point, or if there's an acute or a sudden closure of one of these coronaries, you could have what's commonly referred to as a heart attack. The field of interventional cardiology is designed to provide either ballooning or stenting or other kinds of interventional procedures that can stop or prevent the progression, hopefully, of these ongoing pathologies within the coronary arteries. And so that's kind of, in a very small nutshell, what interventional cardiology is generally, what the job description would entail. Structural cardiology is focusing on heart valves instead of the coronary artery. So the heart has 4 valves, and each of these have potential complications or pathologies that may come up over time. What structural cardiology is working on is hopefully breaking down more and more barriers about what was only, like you said, 10, 20 years ago considered maybe impossible. All valvular interventions in the heart were done surgically. So you had to cut open the chest and the rib cage, and the surgeons had to get into the heart and open the heart and then intervene upon the valve. Now we have these options of percutaneous, which is essentially going through the blood vessels and just making a very small puncture to get into the blood vessels. And then you can go up through the vascular system to the heart and potentially replace or repair some of these heart valves. And that is what structural cardiology is.
Exactly. And what's exciting is, like you said, there's 4 valves, and there's been commercial treatment for these 4 valves. There's been clinical studies to further investigate future devices.
Mm-hmm.
But looking at it, I think minimally invasive tricuspid therapy, which is one of the valves, just got commercialized recently, right, with TriClip and Evoke.
Mm-hmm.
So you're about to step into attending this coming July, where you're going to have new treatment options that patients have never had before, hospitals have never used. And what is that like, being a physician that can offer patients minimally invasive therapies for all 4 chambers? Or sorry, all 4 valves.
Yeah, no, all 4 valves. I think it's going to be it's going to be incredible once we get through this initial phase of the tricuspid intervention. Rollout. Where most places are still waiting for the actual rollout and the use of these newest products. But I agree with you. I think within this next year, I think we'll start to see this in action, and that'll really start to bring up the armamentarium of what we have to offer patients. And I think as it started with the aortic valve way back in the day, I think you start with each valve with patients who are very high risk for surgical intervention and possibly prohibitive risk, so that you don't have any kind of treatment option. And then we may be able to offer something. I think it's incredible. And what's really special about, I think, structural cardiology is you see such an immediate impact on these patients. You're watching hemodynamics, which are essentially the pressures within the heart. You're watching them live on a screen, which are abnormal when you start a given case of valvular intervention. And then when you complete the intervention, you see these hemodynamics or pressure curves are essentially normalized right away.
Yeah.
It's so hard to imagine that this would not benefit a given patient. I think that's what makes structural cardiology very, very cool.
Yeah, it's interesting. Going back, you mentioned ortho, ophthalmology, and IC, structural heart, right? All 3 of those all those physicians are doing procedures that I would say have immediate benefit, right? Be it with ortho replacing hemodynamics and cardiology, and then with retina changing a lens or puncture. But what's interesting is all 3 of those, I imagine, are specialties where you're getting referred a patient, seeing the patient, bringing to the table, and then probably sending back to the referral. When you chose interventional cardiology or structural heart, how big was patient continuity and building that patient practice?
Mm-hmm. That's a great question. I think continuity is very important, and I think cardiology actually does offer that. Yes, if we'd really narrow down on the procedural standpoint, then maybe not so much. But as most cardiologists, you do at least see your patients post-procedurally, especially in the structural world. Like here, it's very commonplace to follow up with your post-TAVR patients, for example, at the 30-day time point, and then again at the 1-year time point. Some of them really do want to stay on, and some are continued to be followed from a general standpoint. But yes, others are, of course, sent back to their referrals because they have a long established care with their referring provider. But I think having that scope of seeing someone before the procedure and then you see them after, and at least up to a year, is very important. That does offer some level of continuity, and of course, we're always available if something else does arise. And at the same time, I think the practice that I look forward to initiating or beginning and setting up practice, I think it's important to have that, and I think that's important both within continuity with your patient base, but also the continuity extends into the community that you're in. I think that's very important because being able to relate to your patients and understanding where and what, where are they coming from and what are they looking for and how can you provide for them. Having that shared decision approach and that mindset of understanding each other is very, very important before we even get to the procedural table.
Exactly. And I think you hit it on the head that what your training, you are a proceduralist, but you do have great patient care. You see the patients, you have your own practice, which is a little bit unique to some of the other specialties in medicine where, I mean, you have the best of all the worlds, right? You see patients, you do amazing, innovative procedures. So looking at your training, I know you're really excited. I want to say congratulations because you're wrapping up, I would say, a decade of a decision
Yeah.
to go into medicine, which is super exciting.
Yes.
Looking at, we could look at the whole time, but specifically maybe the last couple years, which was Interventional Cardiology Fellowship
Mhm.
and then Structural Heart. What was the role of med device in industry? And what I mean by that is you're learning a lot from being in the hospital. You have amazing attendings, physicians that have been in this space forever that provide you a lot of advice during the procedure and following patients and kind of tips and tricks that you don't get from a textbook.
Mhm.
But when you look at the med device industry, did they do anything to educate, support you during your last 2 years?
Absolutely. And I don't think I had a full appreciation of the device industry world until this structural year. Up until this point, yes, you run into some, device representatives and along the way for different products and different drugs and so on and so forth. But when I started, or maybe just before starting the structural year, this past year, we started to get much more involved in seeing what is the actual role, at least in the structural heart world, of what is the entire industry world doing for us, especially at the fellow standpoint. You're totally correct. Yes, we have attendings who have been educating us, teaching us. We have conferences, and then of course within procedures, there's ongoing teaching depending on what's going on in a given case. But especially with valvular heart intervention, so much of what a given case is expected to entail is determined before the patient even gets to the table, which is actually a distinction from many interventional cardiology situations where you kind of find out the anatomical considerations as you're doing the case. Here, there's pre-scan and CAT scans, workups, all kinds of things that's done before the patient even gets to the table. And I have now gained a great depth and understanding and appreciation for where the device team steps in from the industry standpoint in helping guide that decision making. And so, for example, all the TAVRs that we do, our attendings, as well as our device team, our industry team, are doing the workup on the CAT scans to see, what size valve would be appropriate, what considerations should there be from an anatomic standpoint when approaching this patient, and those discussions are had on every weekly conference where everybody's participating, everybody's giving their input on what potential consequences might we run into during this, what complications might come up, or will it hopefully not have any, which most obviously don't. But that involvement and that second pair of eyes to look at every single case is extremely important. That's just from the actual case standpoint. From a fellow standpoint, what's been very helpful to me is being able to interact with them. They've been so available to me. Whenever I've needed them, a text, a call, hey, can we look at the scan together? Sometimes they're just more available than where the attendings are maybe already in a case or they're involved with something else. But these guys have been absolutely incredible, crucial to me to build the knowledge base and comfort level that I've attained over the past year as I move forward, where I feel much more comfortable approaching patient care. And I look forward to whoever the industry reps will be as I move into my next role. It's going to be incredibly important to have a very good working relationship with them so we can deliver the best care that we can.
Yeah, and when you look at the space you're in, it's really exciting from a business standpoint because there's new therapies, innovative therapies. It's a fast-growing market because we see a lot of patients with heart disease as the population ages, right? And when you look at I would say the big three, Boston Scientific, Abbott, J&J, now purchasing Laminar and Medtronic. Those are some of the biggest med device companies in the space, and you'll be interacting with them. And there's also a lot of startups that are trying to address these unmet needs. So it's
Mhm.
really exciting. Just as a fellow, it sounds like having access to review scans is important. You could probably ask, I mean, you're so smart, you have great attendings, but I know some fellows feel comfortable asking industry some questions or hey, can we spend a little bit more time just going through the steps? I've been doing it with my attending, but I just had one question on be it access or deployment or, how we use echo to size, whatever it be, which is really exciting.
All the time.
Yeah.
All the time. My reps have been absolutely incredible before and after cases. Hey, why didn't we do this that way again? Hey, what was that again? They break it down. They break it down. They make it easy. They make it simple. I'm telling you, it wouldn't be who I am without the support of everybody around me. And that includes the industry team, no
Yeah.
question.
Well, that's awesome to hear because I've been in medical device for a while, and my favorite position is fellows because they're about my age. They're really excited about the world. Opposed to attendings are amazing, very nice, but you know how they are. They could be a little bit crotchety, a little bit weathered and jaded. Um, so industry offers, these big academic institutions have access to clinical studies, first in man, or commercial kind of studies. But from a fellow perspective, did the industry was there ever like weekend trips to study vascular, structural heart, PCI, or did they ever set up kind of hands-on simulators for you to work on?
Yeah, I think there's been a range of things. I think going back closer to the beginning of the year, there were definitely the hands-on equipment was brought in, some simulations, some how to deploy valves, for example. The delivery catheters were brought in so we could put our hands on it and without it being in an actual patient, of course, and get a sense of what we're going to be doing for the upcoming year or the preceding year now. And then, yes, maybe a few months ago, there was a couple of courses that we went to ensure that we have the confirmation and of knowledge that we need to move forward in completing fellowship. And with all and many of the big industry companies like you were mentioning, and so where we would go, we would interact with the industry team, and there would be some didactics, there would be some
Yeah.
hands-on, some workshops, and whatever, maybe even some watching some live cases. At the end of which, as long as you kind of have a general set of knowledge of what you're going to be doing, then you're essentially kind of, I suppose, certified to go and use those devices moving forward. I think that's been very helpful as well. There's been a few didactic events here as well outside of the hospital where we're able to discuss either trials
Yeah.
or complex cases or M&M type of thing. And so yes, those things have also been incorporated into our kind of curriculum.
Yeah, and you mentioned earlier a cardiac team approach for deciding therapy and also what valve or product to use. A
Mm-hmm.
lot of times in those meetings, your opinion is important, the whole cardiac team's important, but a lot
Mm-hmm.
of times it's the attending surgeon or interventional structural heart attending making the final decision, right?
Mm-hmm.
So when you move this coming fall into your own practice where you're the one that's going to be stepping up to do these innovative therapies, how can a rep communicate the benefits of their product or what's important to you in the decision making process as you lead these cardiac team decisions?
I think what's going to be important is if, when approaching a given patient, understanding the nuance of each individual case from an anatomic standpoint, from a risk standpoint, and from a patient preference standpoint. I think each of these is very important. And as long as those are all brought to the table in the discussion, which will include the rest of our team, the industry team, as long as we have the input of these on the table, I think we'll be able to come to the collective decision. There's, of course, a comfort level from my own standpoint of what I have been primarily using versus what I've used less of. And I think those will probably equate over time. But at least as I come out of fellowship, I'll, of course, naturally be more comfortable using what I've been primarily using, whether it's
Yeah.
interventional or structural or whatever. And I think that having the input from not only the industry team that I would be more comfortable with, as well as the team that I would be less exposed to this point. It's just natural as part of fellowship. You get more of one than the other in most types of cases. I think that'll help kind of keep it fresh. What are the other things
Yeah.
going on? What are the other options that we have? And how is each device being improved and enhanced? There's almost always a new iteration of each subsequent device. And so it's always interesting to see, how are things getting better?
So we mentioned several times that you're at the forefront of technology, and a lot of these valve treatments are one option. But if you look at TAVR, we now have three valves. You look at left atrial appendage closure, you have Watchman. Abbott's device. You have laminar, which is a totally new technology.
Mhm.
Look at the mitral therapies.
Mhm.
So I want to know, a lot of these therapies are going to be coming out commercialized when you're in attending. So
Mhm.
how do you want the industry to come and approach you and say, hey, listen, Dr. Roy, I know you're having great results with this new product. There's a new product on the market that's totally
Mhm.
differentiated. You know, it
Mhm.
might not be your workhorse, but it could work well.
Mhm.
The data suggesting these 20, 30% patients. How would you answer, hey, how can I make you comfortable with this product so you feel safe delivering and getting these great outcomes with your patients?
Yeah, I think that's a great question. I think it's very important that yes, when someone does approach me with something new, I would always want to start with some level of data. I'd also want to see, has anyone actually tried this yet, and how are their outcomes? What is their comfort level? And
So when you
then,
say, so people that tried this, who
Mhm.
would be important? Is it looking back at Johns Hopkins and the attendings and peers from your class and also your attendings, or who would be important using it? People just in the US or European markets, or
Uh-huh. No, that's great. Yeah, I mean, usually Europe is a little bit ahead. That's, I think, the
yeah.
general trend that we've seen, and I think that is actually important because we've kind of become accustomed to that. Where yes, that's being done a little bit more. There are also instances where yes, people go to often the headquarters or whatever of a given company where they have more of these live models and demos and workshops where they can get
Yeah.
more hands.
Yeah, that makes a lot of sense. So I want to wrap up. I know your time's valuable, but just kind of pointing back to what you said, clinical evidence is the most important. Getting hands-on training so you feel comfortable with a live patient. And also, I don't think reps realize, we do realize, but you have conversation, you guys work so much. I mean, you're getting in the hospital around early, you're in procedures and clinic all day, you're wrapping up around dinner or later. And on the way home, you might call, someone that you're in fellowship with or attending and say, hey, there's this new commercial product. I saw it. Like, what are your thoughts? And if they had a bad experience, I mean, that's going to weigh on you. But also, I know you're open, and if the data makes sense, is okay. How can we, learn from that experience, and how can we have a different outcome? Dr. Roy, thank you so much for taking time to connect with Medical Device Matt. We learned a lot. I'm really excited for this episode. I think you, the physician community, industry, has so much work to do addressing the unmet needs, because these minimally invasive therapies where patients are able to get treated, feel better, and leave the next day are new and they're novel. And 20 years sounds like a long time, but it's not in medicine, and there's a lot of work to be done. More importantly, I want to congratulate you, the culmination of many years of training. I'm excited for you to see where you go next year. The community is going to be lucky to have you. And what I'm excited about in medicine is I'm going to see your name for the decades to come as you help many patients and involved in, future therapies and the research that comes with that. Awesome. Thank you, Dr. Roy. Have a great rest of the week and take care.